Добрий день всім. Ми дуже дякуємо, що ви до нас приєднались. А ті, хто не приєднались зараз, знаю, будуть додивлятись цей ефір. І вступне слово до нашого ефіру я попросила сказати пана Андрія Мизака, нейрохірурга. І ми завдячуємо йому в першу чергу тим, що маємо взагалі таку можливість проводити цю серію ефірів. В першому ефірі був Генрі, пан Андрій і пан Бабляк. І наразі в нас будуть такі серії більш лекційні, де буде дуже багато Генрі. І всім цим ми завдячуємо вам, пан Андрій, за що ми вам страшенно вдячні. І тому прошу вас сказати вступне слово до цього ефіра з Ендрі.
Дякую навзаєм, пані Катерину, для того, що ви нам надали майданчик, щоб підняти болючу тему безпеки, з якої ми сьогодні починаємо. Безпека хворих. Хотів сказати про те, що коли ми говоримо безпека, ми не говоримо про той папірчик, який ми підписуємо інженеру з техніки безпеки. Ми говоримо про безпеку пацієнтів, безпека існує для того, щоб не ставалося б трагедій, фатальних помилок, щоб ми могли якомога більше зберегти здоров'я і життів наших людей. І всю свою медичну роботу, всю свою кар'єру медицини я завжди думав над тим, чи дозволено лікарям помилятися. Пам'ятаєте, точилися дискусії, дебати, можна лікарям чи не можна помилятися. Чи ми надамо право на помилку лікарю, чи ми будемо йому всьому відмовляти, людям властиво помилятися, і лікарі будуть помилятися. Але коли ми говоримо про фатальні або якісь невдалі випадки в медицині, ми мусимо все ж таки прийняти, що помилки будуть. Але для того, щоб зменшити їх максимально, то ми маємо працювати і ще над іншими речами, які би становили базову культуру нашої медицини. Від чого відбуваються якісь нехороші речі, помилки, погані результати? Що лежить в їхній причині? Не тільки вроджена людська приреченість до роблення помилок, але і наші сугубо людські певні упередження. Наприклад, ми боїмося робити аналіз того, що відбулося. Наприклад, часто-густо ми є некомпетентні і хибно оцінюємо нашу здатність робити ті чи інші речі в медицині. Наприклад, ми можемо надавати неналежну допомогу. Часто-густо неналежна допомога надається через те, що медичні працівники мотивуються тими речами, які не мають нічого спільного з головною єдиною метою – лікувати пацієнта. Медична система, як і будь-яка складна сучасна система, це комплексна адаптивна система. І коли ми говоримо про слово адаптивність, це здатність системи визначати, що відбувається в системі не так, систему коригувати для того, щоб вона могла існувати далі. Якщо ми не будемо робити болісний аналіз наших помилок, якщо ми не будемо аналізувати компетентність нашу, чи ми можемо робити те чи інше, чи ми на це не спроможні, через те, що ми не аналізуємо, яка ж мотивація тих чи інших вчинків в медицині, чи якщо всього цього не буде в нашій культурі, то медична система не буде надавати ту допомогу людям, нам, всім, тому що рано чи пізно всі ми будемо пацієнтами, яку би ми хотіли бачити. На відміну від української медичної системи, на Заході ці речі, такий підхід уже давно розвинений. І нам не лишається придумувати нічого іншого, крім як запозичувати ці речі. І для того, власне, ми би хотіли би сьогодні розпитати і нашого дорогого гостя, який вже 32 роки допомагає нам в Україні з розвитком нашої медицини, доктора Генрі Марша.
All right, share screen.
Henry, you may start.
Yeah, let me just get this up.
So I will disappear from the screen, you will remain with the slides, and then I will come back for the questions. Okay.
All right.
Go.
So, Dobry den, good morning from London.
Henry, we do not see your presentation yet. Is it okay or not?
Why can't you see it?
I don't know. I still myself and you, which is very honorable for me. Nice to see myself
Share
with Henry
screen.
Mans. But it's
Hang on.
nicer
Share.
with the presentation.
Yeah, all right. Right. After the usual technical hitch, I will start again. And I'll talk briefly about what is called in English patient safety. Now, this began in the 1990s, and a book was published by the American Institute of Medicine called To Err is Human. To err is to make mistakes. There is a famous biblical saying, to err is human, to forgive is divine. And although the figures they quoted were a projection from smaller studies, this report from the Institute of Medicine estimated between 50 and 100,000 people were dying every year in America, avoidably as a result of medical error. And this was a sort of wake-up call to the medical community, both in America and to the rest of the world. And it has now led to a whole industry of patient safety, some of which is good, some of which is bureaucratic and not so good. But the essential point is that modern medicine is dangerous. And the more drugs you have, the more equipment you have, the more technology you have, the more dangerous it becomes. And to avoid harm, injury to patients, you must develop a culture of patient safety. Now, there are many causes of medical error. There are wrong side operations, as I'll tell you later. I once did that. There are wrong operations. There are surgical complications. There are hospital-acquired infections. There are medication errors. And there are many more things that can go wrong. The important point is to identify bad outcomes which could have been avoided. Obviously, many things happen that cannot be avoided, but the critical thing is to develop an attitude where you look critically at bad results and learn which ones could have been avoided, and you'll do better next time. Now, I'll start with a story about myself. This is the WHO surgical checklist, which was introduced into my operating theatres in London about, I think, 20 years ago. And I was very hostile. I complained. I said, why do I need a checklist? I don't like it. It's ridiculous. I should be trusted. And then my anaesthetist, who is a good friend and with whom I've worked for many years, said, well, Henry, you did once start a craniotomy. You opened the wrong side of a patient's head. To which, of course, I had no answer. And one of the valuable aspects of a surgical checklist is to check that you are operating on the right place. So that was a painful lesson for me. When the WHO checklist was introduced, they ran trials in 8 hospitals, some in high and some in low-income countries. And they said that surgical site infections fell from 6.2 to 3.4%, and mortality was halved. Although it's important to note that the biggest benefit was in low-income countries. In wealthy countries in the West, the benefit of a checklist was less clear-cut. Nevertheless, the checklist now is universal, certainly in all hospitals in England and America. Why was I hostile to the checklist? What's the harm in having a checklist? Well, first of all, as a surgeon, I don't like to think I make mistakes. As a surgeon, we need to be self-confident. We don't want to be full of doubt. And we don't like to be reminded that we might make mistakes. This is silly and stupid, but it's human nature. And then, of course, there's the question of hierarchy. When I'm in the operating theatre, I feel I am the boss. I am the big man. I didn't like to be checked upon by mere nurses and technicians. This, again, was stupid and vanity, but I think it influenced me. I resented being told what to do by managers, by non-clinical staff, and having the checklist forced upon me. And this is an important point. I had no ownership of the list. Nevertheless, I was still more responsible than anybody else for what might happen to the patient. And also importantly, much of what was on the list was completely irrelevant, and from my point of view and my colleagues in the operating theatre, was irrelevant. But if I could send a message back to myself 20 years ago, every time you sit in an aeroplane waiting to leave and the door to the cockpit is open, and you'll see the pilots there going through their checklists, and I would ask myself, the Henry Marsh of 20 years ago, do you prefer your pilots to use checklists or not? And the answer is, well, of course I do. Just like our patients would be happier if they know we are checking things all the time. Because as in the title of the Institute of Medical Medicine report, to err is human. We all make mistakes, however good we are. But having said that, checklists need to be relevant and designed by the people using them. And it is a mistake with the WHO checklist that one size fits all. I went into my hospital today, although I no longer operate there, I still teach. And there you can see the checklist is on the wall and all these details. It takes quite a long time. The surgeons and staff must go through this, the beginning of every operation, at the end of every operation, and a lot of it is totally irrelevant to a neurosurgeon. And the staff have no ownership of this list. It becomes a nuisance. And I was very impressed when I was in Houston, in Texas, recently visiting the world-famous MD Anderson Hospital, where they designed their own checklist. My own feeling is that having one checklist for everything is a serious mistake. And what needs to be done is the people who will use the checklist should design it themselves. They're the best people who know what they need to know to be safe. They have ownership of the list. They're more likely to use it properly. But checklists are only one aspect of patient safety, very much as a superficial aspect. Here's another story about myself. This was a patient who was a Korean woman who spoke scarcely any English. She presented with a benign meningioma. That's the ball in the middle of the scan, a lot of cerebral edema, the white around the tumor. And she presented with confusion, personality change. She was diabetic, and she needed to go on high-dose steroids to prepare her for the operation. So I asked her family doctor to do that, but told him to check her diabetes because it would almost certainly be made worse by the steroids. Because we're always short of beds in English hospitals, patients are usually admitted either the morning of surgery or the night before surgery, having been assessed in a separate outpatient clinic a few days in advance. I went in to see her on Sunday evening. It was late. I'd been held up in a traffic jam, I think. She was very sleepy. It was 10 o'clock at night. She doesn't speak English. I knew she was a bit confused, and I thought nothing of it. And I wished her good night and said I would operate next morning. My anesthetist saw her next morning. She also assumed the fact the patient was very sleepy and rather confused was because of the tumor. So she's anesthetized, routine blood gas is checked. She's severely acidotic. They check her blood glucose. It's over 700 milligrams per deciliter. Her diabetes is totally out of control. we have to abandon the operation, and she dies next day from the profound metabolic crisis. Now, it turns out she didn't have her blood glucose checked by the nurses on admission on the Sunday night, which should have been done. This was a completely curable, benign tumor, and she died without even having an operation. This is an example of what's called the Swiss cheese model of medical error. You put together a whole series of minor coincidental points. She didn't speak English. She was confused because of a tumor. The GP probably hadn't checked her glucose. For reasons we don't know why, the nurses hadn't checked it at night. And so you put all these together, and if the holes align, a series of problems which in themselves, by themselves, don't matter, have a catastrophic outcome. Now, who is to blame? The family doctor? Should I have noticed something was the matter on Sunday evening? Should my anaesthetist? The nurse who admitted her didn't check her glucose? Who should we blame? Now, this really is the most important slide of my talk. To ask who is to blame is the wrong question. What we should ask is what went wrong? And the fundamental insight of the patient safety movement, and I think we can call it the movement, is that medical error usually occurs because of bad systems, not bad doctors and bad nurses. So when there is a bad outcome, a bad result, we shouldn't be saying, who is to blame? Who should we punish? We should be saying, what went wrong with the system that failed to make allowances for the fact we all make mistakes? So patient safety has three components. It is to prevent and reduce error, and checklists are one way of doing that. It is to identify and report errors. That's the most difficult step, to admit to yourself, to your colleagues, that there has been an avoidable mistake, and then report it. And then if it is reported, to analyze the mistake and learn from them so it doesn't happen again. So there are many ways, other than checklists, whoops, hang on, I gave back, that patient safety can be put into practice. You can have morbidity and mortality meetings, which I hope you have. They're routine in Europe and America and England, though they're not always very good value. You can have checklists. You have to have error reporting, so that if there is a bad result or a death, it is reported. The data on bad results, adverse outcomes in English, must be collected. In Britain now, we have a legally enforced duty of candor. By law, we must tell patients and their families when a mistake has been made. Whether that works or not, I think is uncertain, but that is our legal obligation. And then, of course, there is an increasing amount of malpractice litigation, which does give some pressure on doctors to try to be more safe, although it also produces the phenomenon known as defensive medicine, which is particularly a problem in America, where malpractice litigation is a huge, huge business. But the important point about all these mechanisms of patient safety is the simple truth that no castle is stronger than the soldiers defending it. You can have endless walls, battlements, fortifications. You can have checklists and endless forms for reporting bad outcomes, having meetings to discuss them. But if the staff, if the clinical staff, if the doctors and nurses, if their heart is not in it, it just becomes bureaucratic paperwork. Now, patient safety requires a no-blame culture, which is very difficult to achieve. But when there's a bad outcome, the staff are not frightened. They will be blamed and picked upon and criticized. And to have a no-blame culture, you need good teamwork, where people work together, trust each other, and above all, are committed, above all, to caring for patients and to making treatment as safe as possible. And to achieve that, you need good leadership. And you need openness and transparency. This all sounds fine on paper. How do you actually achieve it? Well, you may have come across this book. I've talked about it in previous lectures in Ukraine. Matthew Syed is writing about the way we often make most progress from learning from bad results, bad outcomes. And he illustrates this with several famous plane crashes. In particular, there was an infamous flight in Korean Airways in 1997, so the same time as patient safety was starting to become understood. Airplane coming into land in bad conditions on the island of Guam in the Pacific. The pilot thought he was higher than he was. The ground radar wasn't working, so it was a sort of blind landing. And the black box recorder, you can hear the co-pilot saying 200 meters, 150 meters, 100 meters, 50 meters, and that's it, they're all dead. What did Korean Airways conclude from that? Well, co-pilots should dare to say, hey, boss, you're wrong, you're lower than you think you are. And senior pilots should listen. Perhaps when I operated on the wrong side of the patient's head, although fortunately the patient came to no harm, perhaps if my assistant had dared to say, Henry, boss, I think you might be on the wrong side. And if I had listened, perhaps we could have avoided the problem. And this is what cabin crew training in aviation safety is all about. But there is, of course, a critical difference. Flying an aircraft is not like operating. Safety is in your own interest. If there's a bad mistake, you will die. The problem for us doctors and nurses is if things go badly, we don't die, the patient does. And then, of course, we have to deal with that problem, and it's all too easy to go like that or deny it or hide it. And if you refuse to admit there's been a mistake, it could have been avoided, you will not learn from it, and it is likely to happen again. So this is why leadership is so important. Given that we are not at risk if the patient comes to harm, we as the medical staff, it is terribly important there is leadership which gives a sense of purpose and meaning to what we do. It's very easy if you're working in a hierarchy, if you're one link in a chain, to lose sight of the chain as a whole. And it's the duty of a good leader to constantly give all the links in the chain a feeling of purpose and meaning to what they do. Cleaning the instruments, washing the floor of the operating theatre, it is all vital to patient safety. But if you're a cleaner and people treat you like shit, you will not clean that well. You will not feel part of a team. So good leadership is enormously important. And there are, of course, two models of leadership. There's the old-fashioned model, which is a triangle, the leader on top, and all the employees, the team below. And the more appropriate model for patient safety is the other way around, where the leader is supporting, enabling the team, and providing that sense of vision, of common purpose, of caring for our patients, even though many of the team will never see the patients. They're all part of the links in a chain. With bad leadership, you may know this slide, I showed it recently in Kiev. If it's like that, when top-level guys look down, they see only shit. And when the bottom-level guys look up, they see only ourselves. And that is no way to create teamwork. That is no way to create patient safety. So good leadership and patient safety. A good leader, as I've said already, sets an example of openness, honesty, and being approachable. I've tried for many years to set an example of honesty, writing my books, talking not about my brilliant successes and triumphs, but talking about my mistakes and difficulties and trying to learn from them. A good leader, and this is one of the most difficult parts of it, has to accept responsibility for the team's mistakes. That is why the position of a leader is not one of being one of the guys at the same level as the team. You have to be responsible. and find a balance between being responsible at the same time empowering the team and not blaming it when things go wrong. And as I said before, a vital part of leadership is to provide that sense of common purpose and vision. So even the members of a team who are dealing with bits of paper or washing floors or having to do routine blood tests can see the meaning and purpose of what they do, even though they don't actually see the patients themselves. And what about the situation in Ukraine? Well, as far as I can see, I'd be very happy if I was wrong. Correct me if I'm wrong, although I've been going to Ukraine for many years. I don't speak the language, to my shame, and I only see a very small part of what is going on, mainly neurosurgical, through my good friends and colleagues. But it seems to me the medical system is still very hierarchical, as the English medical system was when I started training almost 50 years ago. Patients have little redress if things go wrong. Patients are helpless and powerless. Patients are always a bit helpless and powerless. The doctor-patient relationship is very unequal. But in Ukraine, it seems to me, patients, there's very little they can do if things go badly. And that has a bad corrupting effect on doctors, I'm afraid. It means you can get away with bad results. You don't have to stop and say, well, actually, I need to think about this. I need to try to stop it happening again. And there is still, I suspect, please correct me if I'm wrong, there is still the old Soviet era tradition of secrecy and Chernobyl-style denial. What problem? No problem, nothing. Denial. So what is to be done? Well, if you're at the bottom of a medical hierarchy, there's not very much you can do, because so much of what I'm talking about is trying to create things partly from not above from a political level or from a managerial level, but from a level of the senior doctors. If the senior doctors are not interested in patient safety, it is very difficult to get it off the ground. But as an individual doctor or nurse or healthcare professional, honesty about yourself and your immediate colleagues is very important. You must try not to run away from bad results, and to understand we all make mistakes and must try to learn from them. And it does not mean you're a bad doctor or a bad nurse to make a mistake. It means you're a human being. The challenge is trying to do something about it, both to do better yourself next time and to help your immediate colleagues and friends do better next time. So does your department have morbidity and mortality meetings? Are they useful? Are they meaningful? Do you have simple checklists? I think the WHO checklist is a big mistake, but I do like the idea of checklists. But these are checklists we should design ourselves relevant to our particular work. Do you keep a record in your department, in your unit, of bad results affecting patients you've cared for? Or do they all just disappear into a black hole? And you can try, even if you're low down the hierarchy, you can try to set an example in your own micro setting, and damn the professors, but not the good ones. I've been coming to Ukraine for 32 years. I'm rather proud of that fact, given that Ukraine has become rather almost fashionable country for Western Europeans to visit. There I am, more 30 years ago, with some equipment I brought out. It was a very exciting time, although very difficult as well, because there was such a lack of modern equipment and modern medicine. It has been wonderful to see the progress since then. It's fantastic. Okay, it's uneven. If you go to one of the big private hospitals in Kiev or the big cities, you'll get first-class treatment, hopefully. But it's the same all over the world. In Britain, the contrast between big hospitals in London, in the government system, and hospitals outside, far away in the north, there's a big contrast in quality of treatment you'll get. So that's to be expected. But it seems to me that although there's been this huge technical progress in Ukrainian medicine, there has not been a corresponding sort of psychological, philosophical progress in the attitudes of many doctors, particularly the senior ones. And above all, about all the elements of patient safety that I've been discussing with you. I think it's too much to expect the old professors to change. We say in English, a dog won't change. You can't teach an old dog new tricks. A leopard can't change its spots. But for the younger doctors, to whom I hope I'm talking, and the more sympathetic, progressive senior doctors, patient safety is terribly important. It's much more than just bureaucratic form filling, bureaucratic ritual. It should be an essential part of your medical practice, just as modern scanning, modern technology, operating equipment, modern chemotherapy is a vital part of medicine. And that is the end of my talk. Thank you very much.
Thank you very much, Henry. I have a number of questions. Let me see if somebody... No, not yet. I mean, I see that you are watched very well on 3 channels, YouTube, Facebook, and Zoom. So we will wait for the colleagues to ask their questions. But for the moment, I have mine, if you don't mind.
Yeah.
I will try to be as short as possible asking. However, I might not be that efficient, but still. When we speak to patients, for example, about their safety, there is always a risk that we are sort of like violating the reputation of the doctor and the reputation of the system. And still, I, as a doctor, would always like to educate my patient about the potential risks, especially in Ukraine. So what do you think the patients should know about the potential risks? And for example, the patient is entering, I don't know, surgery for some planned surgery, big hospital, either a parent with a child or an adult patient. Do we need to teach them any red flags or anything that they need to observe? Or it's not their role at all and they shouldn't be informed?
Well, I mean, in England and many other countries, we have a legal obligation to tell the patients everything. So in a sense, we have no choice. You have to, I'm about to undergo major surgery to my right eye next week for an epiretinal membrane Terson syndrome and a cataract. And the surgeon, I'm a surgeon, but he has to warn me that there is a 1 in 10,000 risk of bilateral sympathetic ophthalmitis. You can go blind as a result of surgery to one eye. It's very, he says he's only seen it twice in his career, but he has a legal obligation to tell me that if I'm one of the 10,000, if I'm the next 1 in 10,000 patient who goes blind, if he has not warned me of it, I can sue legally. So a lot of what we have to explain to patients in the West is determined by medical litigation. So in that sense, it's simpler than in Ukraine, where you have more freedom to choose. That having been said, all neurosurgical operations are dangerous. They all have serious risks. And litigation apart, you have to tell patients about this. How you do it is an art. You can say, well, look, there's a 1%, well, you know, there's a 1% risk you could die. There is a 1% risk you could die. I once saw a patient die. You know, the way you convey this has a big impact. You can warn patients of the possibility of bad results without necessarily terrorizing them. But it's an art. Patients never tell us how well we've spoken to them, so it's difficult to learn how to do it. You have to listen to your own heart to a certain extent. But the whole point is that good medicine is we don't make decisions for patients, we make decisions with patients. And the patient cannot make the right decision with you if you haven't discussed the balance of risk. Just this morning, I was teaching in my hospital. We saw a woman in her 50s who's had an epileptic fit, perfectly well until then, and the scan shows a really big frontal meningioma. She's quite well, even though it's a big, big tumor. That can happen. So I asked the trainees, what should be done? Oh, we got to operate. And I said, well, can we get her better? Well, the answer is no. If she's on anticonvulsants, that will treat the epilepsy. What happens if we do nothing? Well, she probably will remain perfectly well for many years. So every operation is balancing the risk of any treatment, not just surgery. There's a question of balancing the benefits and risks of doing something against the benefits and risks of doing nothing. And that should be explained properly to patients, and they are then involved in the decision. And this, of course, is what is called patient autonomy. It's one of the so-called 4 pillars of medical ethics. Ultimately, it's the patient who decides what's best for them with your advice. It's not the other way around.
To continue my question, our situation, as you very well know since you come here for ages in Ukraine, is a bit more, I would say, particular in a way that we have some systematic mistakes. And we cannot count on the system as a whole, and quite often you cannot count on the facility, because in the same facility, on one floor, one things will be happening, on another floor, different things will be happening. And within this context, shall we teach the patient some basic stuff and say, like, if the doctor is doing this or that, or if he's prescribing this or that, you probably should look for another doctor?
Yes.
How far can we go?
You should. I know it is still to criticize other doctors. Doctors don't like doing that. And that certainly was the norm 50 years ago in England. Even though you saw your colleagues doing bad things, you wouldn't tell the patients that. But at the end of the day, you have to say what comes first, me and my colleagues or the patient. I agree it's very difficult. We all have, we say in English, skeletons in our cupboard. We say people in glass houses shouldn't throw stones. So at what point you say, well, actually, I really ought to tell the patient. Let's say a patient comes to see you for a second opinion, they've had the wrong operation, or I've quite often seen patients in Ukraine where the first operation has missed the tumor. Well, I'm not going to lie. I might say, actually, it's very difficult. I can understand why that's happened. I'm not blaming the first doctor, but, the operation wasn't successful. So there are ways of explaining the problem without saying it's all the fault of the doctor. As I said, an important part of patient safety culture is not blame. It's trying to say what went wrong. And if a surgeon wanted to find the tumor, there will be reasons why he couldn't find it. I don't know, but in England, most patients, if you explain things well, why things, if it's an operation I've done and it's gone badly, it's remarkable how often you are forgiven. Not always, and you have to accept there must be plenty of patients who hate me still, or their families hate me because they think I did things badly. But on the whole, we say in English, honesty is the best policy. Now, I agree. Whether patients are ready for that in Ukraine or not, I don't know. And I work in Nepal, I've done for many years, in the Himalayas. I mean, very much poorer than Ukraine. There, if the families are unhappy, they will kill the doctors or smash all the windows in the hospital. So I agree, you have to take into account the level of education and sophistication. But I think on the whole, my feeling in Ukraine is if patients have things explained sympathetically to them, they accept things can go badly.
Mm-hmm. Then my next question is as well about the culture. Just to give you the example of the last week's situation, I took a patient who is a friend of mine and who is a nurse, very good in infectious control. She needed an operation. It was not a very severe operation, but emergency kind of acute situation. And while being in the hospital, both of us, while me accompanying her and she being in the hospital as a patient, we saw quite a lot of mistakes in infectious control. And since she is the nurse in infectious control, so she saw the mistakes. I asked politely if the director of the hospital wants to have this list. He really wanted to have the list. And basically we gave him the list. And even in 2 days, she noticed that these things are already start to be fixed, which is very good. However,
Yes.
however, the head of the surgery did not forgive her that. And while talking to her in the end, he was kind of getting very cold. Don't come here again with your commissions, and all these kind of things. So the question is, what is the key to this culture of taking feedback? Because she could have remained silent. And of course, I mean, that was one of the options. But basically, both me and her decided not to. So what's the key of this turn in the culture
Well,
that people would be seeking for this feedback?
You have to make a political decision if you criticize, how great a risk is it? Now, will it cause you such severe damage to your, as a junior doctor, if it will wreck your career? It's very difficult to stand up and be critical. But you have to start from the position, one has a duty to try to be critical. I agree, in the real world, sometimes the price is too great. And it's very difficult. As I said at the end of my talk, damn the professors, you know. We'll have to wait for a generation to die, perhaps. But you have to start from the position, it is our duty to try to make things better. And I accept sometimes that's very difficult, if not impossible. But if we don't try, how will things ever get better, you know? So you did the right thing, and that's. I had a similar problem when I was visiting Kiev. I think last year I saw a terrible mistake made. Not because the doctors were bad, they were simply utterly ignorant, and I had a long, difficult time. Now, do I write to the hospital or not? And eventually I felt I had to, partly because this was a mistake made out of sheer ignorance, which means it's likely to happen again. If it had been a careless mistake or something which had been forgotten, well, you know, we all make mistakes. But to make a mistake which reflects a complete lack of training, a complete lack of understanding of basic neurosurgical principles, I couldn't walk away. At the same time, because I'm an outsider, it was easy. I was not running a risk to myself. But it is very difficult. There's no easy answer. But we have a moral duty to point out when things are being done badly. And they will not get better if we don't do it.
Let's say you are a director of a big hospital in Ukraine and you have chiefs of the departments, majority of whom do not want to accept the feedback that something is wrong. And they just take it very personally and
Yes.
they kind of... How can you support this director of the hospital in a way that he's
Well, I
really
think,
trying?
You know, as I said, the message of patient safety is not who is to blame for what went wrong. To take the whole personal aspect of it out. So I think, you know, all the senior doctors should have lectures about patient safety and it's about systems, it's not about individuals. We all make mistakes. And the challenge is to come up with systems which reduce that risk. It's not about blame. And that's the really critical point about patient safety. If I was a hospital director and there were problems, I would try to organize not a training course, but a meeting about patient safety, explaining that this is not about blame. It's about what can we do to make the system better and safer.
In your lecture, you mentioned in the last slide several things which I find very useful and important. And you mentioned the thing which is called record of adverse event or record of bad results. Let's say somebody was watching us today and decides, okay, I want to install this record. So my question first, where should it be? In the department or in overall hospital? And what can be the first design of such a record system? What should be inside? What do you want to record?
Well, it is, of course, quite difficult because, you know, some problems occur outside the hospital afterwards and can be lost sight of. So you have to start with problems that occur during the hospital admission. I mean, the way most hospitals in England function, surgical departments, and in America with mortality and morbidity meetings, is the junior doctors are told to keep a record of all adverse results, and then they're presented every month. In these days of computer databases, in theory, the hospitals have big central data collection exercises, but it's remarkable how, in my experience, how inefficient they are. So I think that the way it works in my own department is the junior doctors record all bad results in patients they're responsible for. Even that often doesn't work. You know, I can see some bad results that doesn't disappear, but it's a start. And then, you know, but it does depend so much on whether the senior doctors in the department are sympathetic or not. If they are, you can sit down within the department and discuss the bad results and say, what can we do to stop this happening next time? And almost always it's not because there's a bad doctor. Most of us want to help our patients, you know, it's because we're human beings. But it is critical, the heads of department, if they're not interested in this, it's very difficult to put it into effect. As I said, I was very antagonistic to the WHO checklist when it was introduced. As a matter of principle, I don't want a checklist. Now I fully accept it's a good idea, although I think the implementation of the WHO checklist is not good.
What should be in the checklist? I mean, what is the...
Well, it depends. That is up for each medical department to decide. What are they need to look at their bad results and see what goes wrong and why, you know, and what can we do to stop those mistakes happening again. And that's why collecting the data on bad outcomes is so important. We learn nothing from success. We learn from failure. And you design your checklists to reinforce safety where things go wrong. I mean, my case, the woman who died because of diabetes, I don't know what happened, but one needed to look at what went wrong when she was admitted the night before surgery. Why wasn't her blood glucose checked? And I don't know the answer to that. Maybe there was an emergency on the ward. The nurse was summoned away, something like that. So you need to look at what went wrong and then say, well, what can we do? Can we make the system stronger to make allowances for the fact it can fail? The fact it failed means the system wasn't good enough. It's no good saying it's the nurse's fault. That doesn't get you anywhere. You get rid of the nurse, punish the nurse. That won't stop it happening again.
Some things are happening just once in a while, let's say, right? And
Yes.
are rare. Some things are happening quite often. From your experience of coming to Ukraine, are there any things which you see regularly which are related to patient safety and, let's say,
Well, I
top
think
three?
infection control is poor, you know, hand washing, very basic things like that, which doctors, including myself, are always very resistant to. Things like that, I think, it depends on the hospital you go to. Obviously, the state hospitals are worse than the private hospitals. But my own, you know, I see such a small part of the Ukrainian healthcare system. I'm reluctant to generalize from my own experience. But I certainly, communication with patients. I often see patients where really things have not been explained well before. The people I work with now, my immediate colleagues, are much better at it. Things are improving, but I can't answer, I can't tell you about Ukraine as a whole. It'd be interesting to know what's happening at the front line with military surgery. They're under tremendous pressure. I suspect they may be learning very quickly and getting better, but I don't know.
Mm-hmm. When you speak about the communication with patients, apart from being honest and a part of explaining the risks, what do you find important in communication with patients?
Listening. A very important part of communication is listening, which I confess I didn't necessarily do very well myself. I got better at it. But if you don't listen to patients, you'll make mistakes. And also listening is a sign of respect. Patients will trust you more. And if you do dangerous things, as I did as a neurosurgeon, the way you talk to the patients is partly protecting yourself. You know, if things go badly, if the patients are convinced you do care for them, you were doing your best, it's less likely to cause you trouble. But of course, again in Ukraine, because there's not much litigation, because patients have very little redress against doctors if things go badly, this has a very corrupting effect on doctors. They can get away with doing, it doesn't matter if there's a bad result. It only matters if they're personally upset. It has no professional consequences for them.
Is there any, if you will look in the last, 20 years, is there any drastic big change towards patient safety? And if yes, then what it is? What are those trends of the big
I haven't seen enough of the Ukrainian healthcare system to judge.
And globally, is there any globally or in Britain or anything which you can, for example, come and explain to other doctors and say, see guys, this is how it was and this is how it is.
Well, certainly that the culture of patient safety has developed over the last 20 years or so. There is much more acceptance of the fact we make mistakes. The trouble is it gets terribly bureaucratized. I mean, I think things are safer than they were. I think the data shows that. And hand washing is better. MRSA infections are much better than they were. So I think there has been progress. But I'm not an epidemiologist, so I'm not the best person to answer.
Okay, so then the last but not the least, and I think a very interesting question, what is your advice on how to build a good morbidity and mortality meeting?
It needs to be run by, first of all, the bad results. If it's a surgical meeting, the bad results should be presented by the surgeon who did the operation. There's a bit of a tradition in America and also England that the junior doctors present the cases. Well, that's silly because they're not going to stand up in the public and say, my boss made a big mistake. So the bad results should be presented by the surgeon who did the operation. It should be conducted by the senior doctor who makes sure important questions are asked, but avoids blaming and finger pointing. The leader must always think, what will we do differently next time? What have we learned from this? This is not about blaming people. So it's a combination of good leadership, but also if you're presenting surgical bad results, it's the responsible surgeon should present it. So it's my mistake. This is what I've learned from it. It's no good having the junior doctors doing it, which is what tends to happen.
Who should be present?
And you need a reliable way of collecting the bad results. Which, as I said, it works reasonably well, which is the junior doctors do it.
Who should be present and who should never be present?
I think in a surgical meeting, only the surgeons. I think the idea of having all the hospital staff or the physios and nurses won't work. I think it needs to be the people in the surgical department, doctors.
but not including the surgical nurse, or including the surgical nurse?
What, you mean a scrub nurse or the
Yeah,
ward nurse?
the one who works in the operation room together with the surgeons, or it's not needed?
Well, and most mistakes with surgeons' operations are not during the operation. They're usually the decision to operate was wrong,
Okay.
or the management afterwards was wrong. But if in fact the meeting says there was a problem on the nursing side of things, then the relevant nurse should be asked to come to the meeting.
Mm-hmm. What should be the outcome of the meeting, or just the reflection and talk itself is the outcome, or there
Well,
should be some
actually,
kind
it
of...
should be written down, a conclusion, what was learnt, what will be done differently next time, an action plan. What was the error? How could it have been avoided? How will we do things differently next time? And that should be a formal record.
And should
That is what happens.
And should everybody see the papers related prior to the meeting, or they should be only in the meeting?
Only in the meeting, I think. You need to it's very difficult to get surgeons to talk about bad results to non-surgical audiences. I think to start with, it should just be the surgeons. But this is the surgical department I'm talking about. And obviously surgery is only one aspect of medicine.
Let's say there was some big mistake and all hospital is whispering about it, let's say for theoretical reasons. So then how do you think this communication inside of the hospital should be built in case something like that happened? Let's say meeting and the mistake was conducted, and then should, in general, the directors, the CEOs, the medical director just keep silence and wait until it all vanishes, or should there be some explanation?
I think there's no easy answer to that. Ideally, the medical director should say this mistake happened, we've learned from it, and this is what we'll do differently in future. There's a positive conclusion to it.
Okay, so we have some comments where people are praising you for the interesting information. And there is a very interesting question from the surgeon whom I know quite well, Ruslan Salinko, who is asking if the foreign CEOs, foreign managers with their administrative teams could change the situation if they come and run big hospitals in Ukraine.
My own feeling is only Ukrainians can solve Ukrainian problems, is my own view. I'm not a great believer in parachuting in outsiders. If you're going to dabble in a foreign country in the way that I've been doing without the language for 32 years, the more you know, the less you understand. And the idea that this sort of foreign team will fly in and change everything is a mistake. It has to come from Ukrainians. Learning from what they've heard from people like me or from visits abroad. But it has to be, the Ukraine problems have to be solved by Ukrainians.
Should patient safety will be taught in medical university, or it's too early?
Interesting question. I think it's more important at a postgraduate level, but the simple principles should be taught, I think, in medical school as well. Ideally, not as a theoretical paper exercise, but by real doctors coming to talk to medical students and say, look, these are bad results, this is what we do about them. But if it's taught just as a list of points and checklists, it just becomes boring and bureaucratic.
And one more thing, let's say mistake happened and the person, the doctor, is eating himself or herself with guilt.
Yes.
What will be your advice to the ones who are eating themselves with guilt?
First of all, in England, we have counselling services. We have psychological counselling depressed, unhappy
Doctors?
doctors and nurses. We call it burnout. Well, when my colleagues or trainees have been very upset, I talk about my own mistakes. I say, this comes with the territory. What we do is dangerous. We're bound to have bad results sometimes. It's a challenge to accept this. We have to remember most of the time our patients do well. And I'd say to my colleagues or trainees, it would be even worse if you weren't upset, if you weren't hurt. But if you are completely obsessed by it and cannot cope with a bad result, then you should leave the profession, or at least stop doing the work you do. I mean, one of the most important and difficult parts of being a doctor is living with failure. I think that's what is special about being a doctor. It's failure. We all fail. Our patients all die sooner or later. We all make mistakes. And it's terribly painful. It hurts. But you have to live with that, learn from it, and carry on. And that's the real challenge and what's special about being a doctor. And it's a huge privilege to have such a terribly responsible job, which hurts so much. If you're a pilot and you're killed, well, fine, problem solved. You don't have to learn to live with a bad result.
So we are on air already for 1 hour. So in the end of this part, first of all, we will tell everybody that there will be a second part, right, Henry?
Not when? In a week's time or 2 weeks' time?
Yeah.
Yes,
we will announce the date. And the last thing for this air, I see that people, everybody is sitting on Facebook in Ukraine, as you know, and all political and other issues are resolved on Facebook and medical as well. And I see that people are very depressed in the last few days because a lot of people are dying in the front line, and obviously,
yes,
like we see the photos of the people who passed away. I don't know, tell us something, inspire us, support us, tell us something nice in the end of this air, in the last minutes of this air.
Personally, I have absolutely no doubt that Ukraine will succeed, although at a terrible cost, at a terrible price. I've never doubted that for a moment, is all I can say. I agree it's unclear what will happen to the eastern territories, but I remain very optimistic. It's easy for me. I'm sitting in London, but I've been out to Ukraine twice already this year. I'm coming again in October. I've always thought Ukraine was an incredibly important country. In the 1990s, I'd come back and people would think I was sort of mad. What's special about Ukraine? But it is an incredibly important country. It's at the front line of, in a sense, Western civilization. And it's just terrible you're paying such a terrible price in blood and suffering. And I wish I could do more to help. But all I can say is I love Ukraine. I always have done. What you are going through is a nightmare, but it's incredibly important. And the civilized world owes you a huge, huge debt. But having said that, obviously, it's very, very painful.
Thank you very much for today's meeting. Hope to see you soon as we planned. Hope nothing will change our plans. Дуже дякуємо всім, хто нас дивився. Версії будуть доступні як українською, так і англійською. Англійська версія буде доступна на YouTube-каналі доктор Булавінова десь біля 7 години сьогодні. Всім дякуємо, хто нас дивився. Thank you very much, Henry. See you soon.